And thanks everyone. I'll take about 9 minutes of your time to talk about aged care technologies and what we're trying to do. And Ed, thank you as well. And a lot of what we're trying to do is aligned with your missions to promote healthy aging, aging at home, ending loneliness and elevating caregiving. I can relate to all of these subjects as well as crossing the digital divide, which are your special areas. And thank you also to colleagues from Northwood. It's been such a pleasure working with you. I regard myself as an honorary Canadian, having found my adopted family in Vancouver at the age of 40. They could have been anywhere in the world. Like most adopted children, I thought my father might have been the Duke of Edinburgh, but I don't fall into half the world's population who are his progeny. But anyway, that's another story. My interest in older people started as a medical student in 1980. And I came across a wonderful geriatric service and chose to do my first job in medicine in that unit. And one of the less attractive parts of the unit were the long stay wards, because they were slightly depressing places, literally in the bowels of the hospital. And we did our weekly ward round, and the older people there were very quiet. But the doctor before me in the job had learned to drive the hospital bus and took a bunch of old people out to the pub on a Friday night. And he said, would I carry on with that? Which I decided to do. And after I passed the test and we secured a corner of the local pub, that became the Friday night ritual. And I remember one patient in particular, George. He was an ex-miner, coal miner. He'd had a pit accident and he lost his right arm. And then he had a stroke, which affected his left side, leaving him severely disabled and needing long-term hospital care. I'd seen George on the ward rounds every week. He never said a word. But in the pub, after his fifth whiskey, which he drank on a glass on the stump of his right arm with a straw, he regaled us with stories of his life, littered with expletives. But, you know, he came alive. And I learned that, you know, in healthcare for older people, there's more than just medicine. There's more than just nursing. Our role is to enhance lives. And then when I left the job and had tremendous support from Jimmy Williamson, who was the professor there, he told me the great problem that he had identified but not solved, which was that 2/3 of the things that really matter to older people for their health, their independence, and their well-being are not reported, let alone met. And he said, Ian, I want you to solve that problem. And I've spent really 40 years of my life since then trying to solve that problem. And you know, the number one problem in that list is loneliness. Around the world, the number one problem is loneliness, which has such devastating effects for poor mental health and indeed even for mortality. So I want to take you into, I'll try and do a screen share at this point. Okay, is that working?
Yeah, it's working.
Great, it will have gone. I was just going, yeah, I'll leave it on the, I'll have to leave it not on full screen. So as John said, our purpose is to significantly improve the lives of 100 million older people by 2030 using a business model that's built on 40 years of research. And we're addressing three interlinked challenges: the unreported needs, which I've mentioned, the lack of recognition of the role of caregivers and the elevation of caregiving to where it should sit in our systems, and the lack of high quality information to help policymakers, commissioners, and providers to address the things that really matter to old people. And the consequences of these problems are a load of human misery, unnecessary pain, suffering, loss of independence for millions of older people, undervalued, frustrated caregivers, unable to deliver the best care they would like to older people, And without adequate information, wasted resources, lack of efficiency and effectiveness in addressing the things which really matter. The aged care technologies proposition starts with some general elements of thought leadership in defining excellence in what compassionate person-centered care for older people looks like and enabling its spread across the world, where we share learning from the great people I work with, including Northwood as a leading provider of compassionate person-centered care. The formal attempts to create a global coalition aligning policymakers, product developers, businesses, commissioners, policymakers, services, practitioners on a combined mission to deliver compassionate person-centered care for all people, and working locally in the sort of coalitions that have been established with Aging 2.0, Living Lab, Northwood, Dalhousie University, and technology providers, Canadian technology providers that I'm privileged to be working with at the moment in providing in our coalition. The aged care technology work, in order for it to be easy to access, easy to use, and easy to scale in multiple countries and geographies around the world, has to be technology enabled. And we've spent the last 2 years trying to perfect our technologies so we can deliver our assessment, our training, and our analytics on platforms that are easy to access, easy to use, and easy to scale. And we monetize the business through charges that relate to the use of the products and the services, but they're not very high. The assessment tool, for example, is about 40 Canadian dollars per year per person for its use. And given that we know it adds on average 1 extra year of quality of life and a saving of about £33,000, which is about, I did the calculation earlier, I think, let me just check, 57,000 Canadian dollars on average in reduced long-term care costs. That's not a bad return on investment for 30 or 40 Canadian dollars a year. The training that's available online, the analytics, where we integrate data from across the world to understand patterns of needs and interventions which work. And we provide some advisory services. I mean, on the advisory service, I'm involved and with colleagues as well, but I'm personally involved as an advisor to the World Health Organization, helping to develop global policies to promote compassionate person-centered care. And I've been involved with advising national and local governments and health services and systems around the world. Our training started with training in the person-centered assessment methodology, but with working with international experts, we've developed now a set of training products that will help caregivers, and that includes family caregivers, paid care workers, and professionals, health and care professionals, to deliver better care for older people, based on 2 core principles: understanding how to deliver care with compassion, and second, understanding complexity, because what people don't recognize is that when you've met one older person, you've met one older person, and older people's needs are incredibly complicated, to do with biological changes, medical conditions, environmental, social factors, and mental state and well-being that come together in a complex equation that means you have to embrace the principles of complexity in order to deliver person-centered, compassionate care. Our analytics offer it includes a global database and also the provision of data to our customers that use our assessment tool. And I think colleagues from Northwood might be able to talk later about how these data were helpful in shaping the development of Northwood services and indeed influencing policy at the state level. We found that there were very high levels of problems relating to mental health and well-being in the population served by Northwood, which allowed the Northwood to start to address these needs. And I wanted to look back to the beginning to the ACT assessment tool. as a practical method. And what's key to this is not just assessment, it actually helps mobilize a response using community assets to address the things which really matter to older people: loneliness, pain, need for support and self-care. And depending on the community, we get a different response. Depending on the individual, we get a different priority. Our latest work in the UK established the number one need in a very poor community of retired older people was actually wanting advice about finances. And by referring older people to advisory services, we liberated a lot of benefits to which they were entitled but not claiming. So it can be a whole range of things using community assets. The method's been substantially validated, and it's been shown to reduce suffering, producing great outcomes for old people, and on average adds 1 extra year of quality of life. Now that also translates into a compression of morbidity of about 1 year, hence the saving in the long-term care costs. And if we achieve our mission to, by 2030, have significantly improved the lives of 100 million older people worldwide, we will, that should translate into a cost saving to the global economy of about 5.7 trillion Canadian dollars. Having established our work in Canada through Northwood, we're really keen to extend our work in Canada, partly because of my personal connection. I would like to work in Canada, partly because I think Canada has progressive culture and politics that really want to put citizen, patient, service user first. And I think this is a great opportunity for us to share what we're doing in partnership with Northwood, and you'll hear from my Northwood colleagues later, an offer which I would like us to be able to extend to benefit other older Canadians.